Good evening, ladies and gentlemen, and welcome. First of all, can I say that many of you are familiar faces, whether that is because you've been on LPCs for years like me, or whether you're people who were unfortunate enough to pass through my hands as undergraduates. I feel that I'm in a room almost full of friends, and I'm very grateful for you to make this effort tonight. I hope you've all had something to eat. I know that the gluten-free arrangement was not quite all it should have been, but as I always like to say, there were plenty of chips. We have one purpose tonight, and that is to welcome Simon as the Chief Executive of PSNC. It's my pleasure to welcome him and to throw him to the lions that are the contractors of Merseyside and Cheshire. Simon, I could go on, but I think we need you to speak.
Okay. Thank you, Ian. Can I just say it's already started. I only went to get an orange juice, and I've had a very forensic and thorough interrogation already. So this is I've had the warm up, if nothing else. Thank you very much. It's lovely to be here. Expectation management, of course, how annoying. It's as frustrating for me as it is for you that there are some things about the intricacies of the negotiation that I can't go into. Ask any questions you want. I'll tell you if I can't answer them. What I want to do today is just to give you a sense in the imaginatively titled PSNC update of where I think we are. We're in a very difficult place as a sector, as you know better than I do. I want to give you a sense of what we're doing about that. I want you to question and challenge. I have my colleague Gordon here, so if I can't answer any questions, he can, I'm sure. No pressure, Gordon. And failing that, of course, we have our esteemed committee member, Dr. Cubbin, who will also jump in. So if you're happy with that, we'll go through. I always find the benefit for me is about the questions and the discussion. So my presentation is going to be relatively brief, but I'm very keen indeed to have as much time for questions and your questions as possible. And I've already realised I'm not standing in the right place for the video, so I'm sorry about that. Already fallen at the first. Where are we? I think that coming into this sector, I've been in the job just over a year now, and Ian was on my interview panel, so if there's anyone to blame, it's him. Clearly there is a sense of uncertainty in the sector. Unsurprisingly, there is a lack of direction as well. Uncertainty, are we here to supply or not to supply? Are we here to provide services or not? In terms of the annual contractual framework negotiations, well, it's hand to mouth. What's the future going to look like? Do I hang on as a business for a little bit longer in the hope that next year is better than this year? And in doing so, do I invest? How do I invest? Where does the money come from? 11,600 community pharmacies in England, is that the right number? Am I going to be cut? There are some very difficult things hanging over us as a sector at the minute, and that's very clear from someone coming in and spending a lot of time going around talking to many of you around the country. And of course the financial pressures are acute. Reimbursement has not risen in line with purchase prices, that is clear. The concession pricing system is too slow, and of course costs are rising, as you know better than I do. And a combination of all that and margin recovery, clearly the cash flow is a huge problem. I've said to ministers that as a sector we are on our knees financially. It's been caught up in C&D as well as an article, as a headline. I've said it to officials. Make no mistake, we as PSNC are very, very clear indeed to say to anyone who will listen that that is the case. And we are, as you'll see as we go on, working hard to try and find some resolution to that. And there is some optimism. There's some optimism. When you read the long-term plan, you can see that there are references to community pharmacy. There are references to what government wants community pharmacy to do in terms of the NHS long-term plan. But there are also challenges associated with that as well. This creation of primary care networks and the difficulties and the confusion that has associated with it as well. So an unsettled picture, I think everyone would agree. And the challenges for us, well, clearly there's relatively little leverage in having only one buyer as our only customer. We've had a breakdown in our relationship with government. Okay, it's in the past, but trust takes a while to build on both sides, and you would not blame PSNC, you would not blame PSNC committee members, I think, in being wary of some of the initiatives and the suggestions that government's making, and equally, on the other side, government is wary of whether community pharmacy can deliver in some of the areas that they need us to. Are we going to take them to court again? What's going to happen? Can we be trusted to deliver? And that it causes difficulty between us, and of course slows process down. And of course, as a sector coming in, we have such a wide cross section from multiples and independents and independent multiples and online and distance selling but PSNC, we represent everyone, and we need and will work to get a contractual framework that suits everyone. That clearly is not easy, and it's the solution that actually nobody doesn't want, and that's as perhaps as best as we can get. But we will strive to achieve it. There's a strong need for transformation in the sector. The customer demands it for the future. The patient, I think, wants it, and I think many of our businesses require it in order to move on. And I'll say a little bit more about that later. But then the final point is about, I guess, primary care networks and the fact that these are network contracts. The money flows through general practice, and there is the creation of the clinical pharmacist, and how does community pharmacy interrelate with the clinical pharmacist within a primary care network. There could be 10, 14 community pharmacies, and the different roles that clearly will be subdivided up between them. There are challenges there for us on how we work in that new environment. So what does the government want from us? No surprises in item 1. They want more value for no more money. They want, and they've said there's no more money for doing the same things. So clearly we have to look and become more imaginative, certainly as PSNC, to work out how we work around that. But look at the things that they also want that are potential opportunities for us. They want us to help reduce the pressure on urgent care. They want to help us with us to help them with minor conditions. The digital minor illness referral scheme. It's no secret that the long-term plan suggests that they want that as a national rollout. And if that's the case, then what's the next iteration of that? Probably the referrals from general practice into into community pharmacy of minor illness. So there is an opportunity there to, as they put it in the long-term plan, use the clinical skills of community pharmacy in a better way. Prevention. Ministers love HLP. The first time I met Steve Brine, unfortunately now departed, he talked about HLP. He talked about how we can make more of it. What can we do with prevention and at the centre, community pharmacy at the centre of prevention in the community. And of course, medicine safety, and all within, as I keep going on, about the primary care network, and we may explore a bit of that with questions subsequently. But how do we make these changes? Well, we've got to find more efficient ways. If there's no more money to do the same thing, well, how do we do the same thing in a different way? And that means we have to explore, as PSNC on your behalf, we have to explore automation. Automation is in the long-term plan. Government said it wants to look at how automation might help efficiencies. Yes, that means looking at whether hub and spoke is now the time. Is it right to look at hub and spoke to see whether we can have a level playing field for its use? The delegation of work within pharmacy teams, how can that free up capacity? Can it free up capacity without jeopardizing patient safety? And of course, engaging fully at a local level with LPCs, but also, as you'll see later, with GPs and with other pharmacies within a primary care network setting. We tried to get the ball rolling with an animation, and I will play it. I don't know whether you'll hear it. There are subtitles on it. You may have seen it. I apologise if you have. I'm going to play it again anyway, but it is designed for contractors and is designed for people to get people up to a level where they can start to think about what some of the changes might be like for community pharmacy in the future.
Every day, 1.6 million people visit a community pharmacy in England. They are a vital lifeline for people across the country. Pharmacies help patients get the medicines they need when they need them, and pharmacy's biggest customer, the NHS, gets great value for money. Community pharmacies also provide a range of clinical services, giving over 1 million flu jabs annually, providing access to emergency contraception and helping people to understand their medicines. Pharmacies will become even more important as the NHS landscape continues to shift. People are getting older, and almost a quarter of adults report taking 3 or more prescribed medicines. This increasing demand for healthcare services, along with financial challenges, means pressure on the NHS is mounting, especially on GPs and A&E. The NHS long-term plan says the government wants to use community pharmacists' clinical skills to help tackle the challenges facing the NHS. PSNC will negotiate these changes with government on behalf of community pharmacies and will continue to work closely with other pharmacy organisations. In future, community pharmacists are likely to spend less of their time dispensing medicines. Instead, the focus will shift to services that help people to stay healthy and take pressure off other NHS services, such as urgent care. This will include prevention and treating minor illnesses, with pharmacies working closely with GPs and other providers in primary care networks. As income streams change to reflect this, community pharmacists must adapt. With support from the NHS, they'll need to make better use of technology and other team members' skills to free up pharmacists' time, find ways to interact with patients digitally, and update their own skills to provide the services the NHS needs. If community pharmacies can show they're ready and able to provide new services, new opportunities will follow. To give your pharmacy a head start, why not start a conversation with other local pharmacies about how to collaborate within primary care networks? Talk to local GPs about their plans for the future. Take all opportunities for further training and to provide services. Make contact with your LPC. Finally, Make sure you keep up to date by signing up to psnc.org.uk/email.
So, what are we doing? Unsurprisingly, item number one is trying to negotiate the best possible deal that we can for you. We're in the middle of it. We have a good negotiating team made up of representatives from each part of the sector, independents and multiples, people who are long-standing and committed PSNC committee members, and we are, as I said, in the process, and it is difficult. I've said that I think this contractual proposal from NHS England and DH is possibly one of the most radical and complex proposals that we have had for certainly over a decade, possibly 15 years or so. And I'm, clearly I'm only a year in the job, but from my perspective, talking to colleagues who have been there for that long, that is their view. Central for me to a successful outcome is a multi-year settlement. Not only is that essential to give you a sense of what the funding envelope looks like for the future, so that you can make decisions based on that knowledge, whether it's to invest for the future or whether it's at the other extreme to cease trading. But you need to know, and it is, I think, interesting to that there is occasionally pushback from ministers about why are you so special in community pharmacy that you need to know that information? Well, we counter with the fact that it is community pharmacy that purchases the medicines at its own risk, at such great value for the government. It's community pharmacy that dispenses those medicines to the population. And it's community pharmacy that is the NHS on the high street, and 95% of our income comes from NHS, so we have a right to have a sense of what direction financially government is going in. And moreover, I think having a multi-year settlement is essential if we are to have a change programme in order to deal with perhaps some of the services that we talked about, and the future being more service-led than supply. We need to push clearly for a better concessions process. My team in PSNC in London is spending more and more time negotiating on a monthly basis with the department on concession prices, simply because of the quantity of disputatious data on both sides. It is more and more difficult to find common ground and to get a concession price granted, which is why we're seeing this at the end of the month, which does you no good from the point of view of your buying and your risk taking. We need to look at new funding models. We need to look at the different options that might be available. People talk about the funding model being broken. I'm not sure whether it's broken or whether it just needs badly refining. And clearly the cash flow issues that I talked about earlier, and the difficulties that you are experiencing, each of you, with money more generally, from the point of view of margin recoveries, of overall sum reduction, as well as concessions, shows how difficult it is at the minute for you to stay afloat. And of course PSNC, quite rightly, is spending a lot of time behind the scenes trying to influence those people who are going to make decisions on those key areas. Not just politicians or parliamentarians, but also people within the BMA and Royal College of GPs, and within officials within government as well. having a single voice, working together with the other pharmacy bodies, is essential to our future. Government is brilliant at finding the differences between us and exploiting them. And if we don't speak as one voice, we will be done to. And therefore, the relationship that PSNC has with the NPA, with the CCA, with AIM, with the PDA, with the RPS, other pharmacy bodies are available. That is important, vital to our future. And I'm pleased that we continue to work together and we continue to speak with one voice. Yes, of course, people are going to do their own lobbying for their own members as well, but actually when it comes to the key important parts of community pharmacy and what community pharmacy can deliver, we're speaking as one, and that must continue. And then finally, of course, the business as usual. It's rare that it's rare-ish that I get the chance to say thank you to you. It is your levy that pays for us and what we do. We're doing all that. We're also on a day-to-day basis working for you, supporting LPC, supporting you directly with your questions, providing guidance on matters relating to services, relating to legislation and regulation. The Pricing and Audit Centre, the PAC, a team of people in Enfield who just on their own save contractors millions of pounds every year by checking prescriptions. Of course, we are negotiating monthly on concession prices, briefings, webinars, events like this, and our website, which I know our website is a monstrosity. From someone who comes from outside the sector, looking at it, trying to find anything, it just seems an absolute nightmare. But the feedback we get on the website is very positive. Thousands of unique views every day, and every 4 seconds someone new accesses it. And clearly it is a vital tool for many people with the information it has on it. So, what are the priorities for me, for PSNC? Of course, agreeing the contractual framework as soon as we can for this year. We're already negotiating for the year we're in. That is never a good position to be in, but Brexit has caused delays, not from our side, but purely from the department side, and their inability to engage with us on the contractual framework until there was some spare capacity in their teams that were also dealing with Brexit. Providing good, better advice to LPCs to enable contractors, to enable you to engage at a local level on primary care networks. We need to do more. We will be doing more during the course of the year. Don't forget, primary care networks don't really officially come into force until July. Well, we're ramping up to help provide that advice in good, timely fashion. Collaboration, I've already mentioned, with the other pharmacy groups, but also with government, and making sure that our relationships, that trust issue that I talked about earlier, that we start to build a trust relationship with government again, exploring those new ways of working that I mentioned, whether it's hub and spoke, whether it's using automation in different ways, promoting our pharmacy services more generally, and making sure that we are capturing the value and the stories that of what you do every day, and getting that across to government, because it doesn't. Again, coming in, I'm amazed at how we are unable to capture the value that we do and get it across to the people that are making decisions about our future. Because the people who are making decisions about the finance and about our future are not pharmacists. They're people like me. And so we need to capture those stories to make sure that the people like me, after a year here I understand, but that they understand also about what it is that you do and what you bring to the healthcare environment. So, we're at LPCs and all this, an increasingly complex environment, but at a local level for the future, it is the local environment that will be the test bed for new services. One of the reasons why that the digital minor illness referral scheme is being rolled out in the way it is because NHS England wants to ensure that you have the skills, the clinical skills, to deliver it safely. I have no doubt, based on the data that we've seen in the North East and elsewhere, that that is a given. Once we have done that, other services will follow, as the animation suggests. And in doing that, we will still need to pilot some of those services in order to persuade NHS England to take them up and to roll them out nationally. Locally is the perfect test bed for that, and LPCs are a great vehicle in order to capture that data and feed it back to us so that we can use it with NHS. Capturing that examples of good practice, leading the collaboration. Where primary care networks are not working in the future, how do we deal with that? Well, we deal with it by you reporting back to your LPC where it's not working, and the LPC hopefully working with the LMC to deal with it and sort it out. If that doesn't work, then they can send it up to us, and we'll try and deal with the BMA and others and NHS England to make it work. But it is absolutely a pyramid of collaboration in order to make those primary care networks work. And finally, what can you expect? Well, you can expect better support from us. We've already improved our and changed our LPC support, and we will be doing more to do that so that to help to enable you on the ground to do your work better. That's all I'm going to say. It's a whistle stop, but I want to get your questions, good, bad, ugly, challenging. I absolutely get it. I want to hear what the issues are for you and how we can help and what we should be doing that we're not. Over to you. So, what are we doing? Unsurprisingly, item number one is trying to negotiate the best possible deal that we can for you.